Thank you, and I apologize to my fellow panelists ahead of time. I'll be dashing out of here at 3 o'clock. So with that proviso, I will take only 15 minutes to make sure I have a chance for a question. Also, a lot of the slides that I've prepared have not been preempted, but alluded to or addressed in the two previous speakers. So I'll go pretty quickly and then concentrate on the last 3 slides. I should also mention a bias. I am a child's rights advocate. I will, above all things, protect, defend, promote child's right to the highest attainable standard of health possible. No one has a right to be born healthy, as we know, but the Convention on the Rights of the Child does give the child that right. And also the fact that, particularly in the screening context, and I will concentrate on the newborn screening context, the right of the at-risk asymptomatic child to be found and treated. So we'll get past the outline. I think we know it's used whole genome screening in clinical situations where there is a question of diagnosis. We will hear from Robert Green about Brigham. Ellen mentioned Francis Collins. I should say that the PHG Foundation in the UK has looked at the possible introduction, and even though they conclude in a rather wishy-washy way that whole genome sequencing, once sufficiently robust, scientific question, once affordable, health systems question, it could happen one day. Well, we all know that, I think. And the bottom reference is to a study that just came out in the European Journal of Human Genetics, but actually is a report that was issued by these authors in 2010 at the Dutch Health Council in the Netherlands, again arguing against the introduction of whole genome sequencing in newborn screening programs. We're not talking about the introduction of whole genome sequencing in pediatrics or pediatric testing or clinic, specifically whole genome screening programs. And finally, in 2005, the UK Human Genetics Commission, also in a report called Profiling the Newborn, argued against the introduction of whole genome sequencing in newborn screening programs. So the author, there he is. Aaron, where are you? I've lost you. There he is, and thank you. And there's your data. You did mention in the abstract with this article that it's interesting, slight difference between that 74% of parents were definitely or somewhat interested in the newborn screening program, it being offered, whole genome, and interesting, 70% were either definitely or somewhat interested if it was a pediatrician's office. Interesting little twist, maybe because of payment issues or whatever. We'll see. That could have been behind it, but I won't surmise on your data. Again, we had a slide from Yvonne Bombard. This is new, very new. In fact, it was just submitted 3 days ago. And this is 1,213 Canadians representing all the different, across Canada, different provinces. And the study was between targeted, integrating a whole genome into untargeted in a newborn screening program, or targeted for a limited number of conditions. And I really was very interested in their conclusions. You can see the bottom 2 points illustrate their conclusions, but their sentence struck me that our results suggest that integrating whole genome or exome sequencing into newborn screening in an untargeted fashion, so the whole, whatever is up there and possible and can be done whether we understand it or not, might reduce public participation in newborn screening, as well as the moral authority that newborn screening programs rely upon to ensure population benefits. That says something, and we'll have to think about it, as Ellen just said. Some other great, absolutely super articles just came out July 15th, one by Wade and company in the annual reviews, and another, as I alluded to, by Beth, and I quoted, Tarini and Aaron Goldenberg. And the Wade Tarini Wilfond one also gave a very handy table, which I suggest you look at. I'm more, after the talks we just heard, I'm actually not going to go there, but you have a whole table about the types of health information, then the kind of pediatric uses, and then the challenges. And I think the challenges we've already started looking at. I'll go very quickly. The number of false positives, the unanticipated findings, problem of clinical validity, clinical utility. There might not be prevention and or treatment, concerns about harms to children, lack of high quality information, and so on. And the health benefits are unclear. Reproductive risk may be confused with personal health risk, and so on. This is an excellent little tableau, as we say, of what needs to be discussed. And I agree with the last comment. It's what the public wants. True, they can get through consumer direct testing, and as prices fall, they will continue to do so. And what they will go privately or with their children and so on and pay for is one thing. But a newborn screening program, this is my other thing besides a child's rights advocate, is a public health paid for by the state as an example of the role of government in protecting the vulnerable. That's called in law what's called the parents' patriae power. It's the parents' patriae duty of the state as well to protect the vulnerable, be they children or incompetent adults, disabled, and so on. And we have to be very careful when we muck around with public health programs. Once they're gone like the 5 million spots. So again, in the Wade article, a beautiful table again, particular this time to what to do about a population-based test. And I think if we're going to talk newborn screening talk, let's talk population-based tests, which is the title of this session. It is generally recognized that there should be a high burden of proof. We all know the Wilson-Younger criteria from 1968. Here again, a high burden of proof demonstrating the clinical utility of a population-based test and a non-existence of evidence supporting population whole genome sequencing suggests that extensive research will be needed prior to its implementation. Population-based whole genome sequencing is unlikely, the P stands for pediatric, is unlikely to be warranted in the near future given the need for research to resolve a host of ethical and practical issues. I think we need to hold steady, because we're going to lose a lot more than we're going to gain by jumping on the pediatric population-based whole genome sequencing. So in an article which we just submitted 48 hours ago, several authors in our center addressed these headings, which came, I think, from the, I'm not sure if it's the Goldenberg or the Torini, but one of those annual reports, and re-examined it more from a health systems point of view. And I think it's self-evident what the issues are, but I'd like just to briefly mention the last one, which is even in classical newborn screening, if we start resolving the storage and research issue as distinct from the classical issue of should parents consent, give permission, or whatever, if we start to store and use these spots for research, we are in effect creating newborn biobanks. And if so, then what kind of consents and so are we going to apply to that particular situation without harming the participation in the screening itself? So we have to be very clear that we don't touch what I call the child's asymptomatic child's right to be found. Now, Ellen used the word permission. Parental consent for me to this right is a non-starter, so I'm already back. I would even say that parental notification is sufficient to respect their authority and their duties under law, but at the same time recognize the child's separate rights. That doesn't mean that some states might not choose to say you'll be notified and you can opt out. That's a different issue. And some states have done that. I know that in European countries and in most civil law jurisdictions around the world, parental authority does not extend to refusal to participate in newborn screening. It's a newborn's right, nothing to do with parents. After that, if you decide you want to make your child a vegetarian or whatever you want to do, send them to religious schools, that's a different issue. And so not to touch that notification with potential opt-out from the kind of broad consent for future unspecified research purposes that we've been using in population biobanks. If we have that, we have to make sure that that kind of trust of a broad consent for unspecified future research uses are accompanied with the necessary governance processes and data security processes that enable that trust to be secure. And so the experience we have from about a decade of this in population biobanks around the world is that there's no sense in having storage if it's fully anonymized. It's meaningless. This data is static in time. It might be good for surveillance. In other words, how many, without knowing where they are, HIV cases were there, which we know changes 6 months after birth, never mind, in, let's say, 2012, and in a population of newborns 5 years later. That kind of general surveillance data would be the only thing that those storage would be good for. It's a form of research, and it's a form of public health research, as you know. But anything else would not be very productive, both from a cost point of view or from a research point of view, because unless it's coded and you can keep it up to date, even if it's one-way encryption or whatever you decide to do, it won't be of any help to the newborn. It might be help to the population as a whole. So we have to be very careful when we're designing new storage and research programs with proper consents to think about how we can best benefit the pediatric population with such an approach, or if we have the courage to go with the coded way, how we're going to have this whole of return of results for the child's benefit, et cetera, et cetera. So I have 2 slides left. In this particular arena then, the issue of databases that we have seen coming out of several screening programs, including breast cancer in particular, where I've been involved in the large COGS International Consortium. As we create research databases that are valuable and they become international, we know that there are open ones with aggregated data and there are controlled access that are very well controlled. So when we're thinking storage and research, we have to look at the models coming from population or international consortia, research collaborations that have very well, I think, to date, protected the data and the participants. Now, don't put up your hand and tell me about the gimmick, what if one day somebody hacks, or what if someone does the surname inference with the sample with the data. I don't think you can build good public policy on hypothetical, very rare cases, so I'm not going to go on that one. Largely, there have been very rare privacy breaches. So back then to the beginning, we have to remind ourselves in this debate to separate it from what other individuals such as ourselves might or might not want to do with our data or know about ourselves and what we think WGS whole genome can offer. We're talking public health systems and the values that lie behind it. And that has to be up front and center. And the little kid in the T-shirt and everything, it is that child's DNA. There is absolutely no doubt about it. But that wasn't the point about newborn screening. Another advantage to storage, and even if one day we do whole genome and have every little baby with a prospective, predictive, susceptible, or resistant health report card at birth, one of the greatest advantages would be surveillance for stratification. I live in a country with a universal healthcare system. I work with researchers in Europe and so on who have them. They see the biggest advantage of this is stratification for targeting. Because states cannot continue, even universal healthcare ones, to continue paying for everything for everybody, even though that's what they do. The H1N1 scare in December, 2010, everybody in Quebec had to go get vaccinated. From a public health point of view, it made no sense. But because we hadn't stratified and because we hadn't targeted, we didn't know who were resistors, who were transmitters, and who were susceptibles, and so on. So I think using the newborn population as a reference database for better public health planning and targeting would be fantastic. The duty to follow, I'm also a law professor. It's a mess. I wouldn't want to be a pediatrician with such a health card that I'd have to track. You know, it's like in law firms where we're following, we'd have to track, you know, well, what's up, there's a new test, I've got to go back to change our mind, we've got new information, we didn't see this, and so on. And I was an expert witness in a case a year ago for someone who got sued 30 years on a duty to warn case in pediatrics. In Europe, the family unit is considered as having distinct rights. Very interesting. Won't go into it, but it is coming in the duty to warn biological relatives, physician liability. And finally, to conclude, there is supposed to be an emerging right not to know. And on a rather, I'm wondering if that's what it's going to be one day, that we'll spend more time telling what we don't want to know than what we do want to know. But as far as the child is concerned, I think that is a personal issue for parents as individuals. But for children, I think we need to make some definitive pediatric choices that protect their interests. Thank you.